Great. Welcome, everyone. Thank you for joining us today. This webinar on healthcare disparities in diabetes is part of our Harvard Medical School series entitled Addressing Health Disparities, Clinical Insights on Race and Social Justice. I'm Dr. Enrique Caballero. I'm an endocrinologist and investigator and director of Latino Diabetes Health in the Division of Endocrinology, Diabetes, and Hypertension at the Brigham and Women's Hospital, and faculty director of diabetes education in the postgraduate medical education department at Harvard Medical School. I'm also the chair of the Healthcare Disparities Committee for the American Diabetes Association. So again, welcome everyone. I know that many of you are here in the US, but I also know that some of you are outside the country. Welcome everyone. Before I introduce our guest for today's webinar, let me just go through some housekeeping messages for all of you. This program is being recorded today, and the link for the video will be available within a few days. The recording will be shared via email and will be posted on our website, and continuing education credits will be available. When today's webinar concludes, you can click on the evaluation link in the description below in this video window to obtain continuing education credits. So I hope that you enjoy this program in which we will address how diabetes affects racial and ethnic minorities, one, of course, of the groups that is heavily affected by this disease. And it is really my pleasure to welcome two good friends and colleagues for this webinar. And I want to introduce them based on how they are going to be participating in this program. So first, after I go through the introduction of the topic in a few minutes, I will hear from Dr. Gary Puckering. Gary, thank you for joining us today. Dr. Gary Puckering is the president and CEO of the National Minority Equality Forum. It is a Washington, D.C. based non-for-profit organization that he founded in 1988. The National Minority Equality Forum addresses the critical need for strengthening national and local efforts to use evidence-based driven initiatives to guide programs to eliminate the disproportionate burden of premature death and preventable illness for racial and ethnic minorities and other special populations. Under his leadership, the National Minority Equality Forum launched the National Health Index, formerly known as the Zip Code Analysis Project, back in 1998, with support from the Department of Health and Human Services and the Robert Wood Johnson Foundation. And we will hear today some fascinating data that he has been collecting over time about how diabetes, in this case, has affected our country and different populations. I'm also pleased to say that Dr. Puckering, in addition to graduating with the highest honors from Brown University, he achieved a tenure as a history professor at Rutgers University. So he also knows a lot about the history of these important problems that we'll be discussing today. And I also want to welcome Dr. Arshia Baig. Arshia, thanks for being with us today as well. Dr. Baig is Associate Professor of Medicine at the University of Chicago. She is a primary care physician and also a researcher. Dr. Baig has worked on community-based research projects to improve healthcare delivery to low-income, uninsured Latino communities in partnership with faith-based organizations, both in Los Angeles and also in Chicago, where she is right now. She's currently working with community health centers across the Midwest to implement diabetes group visits, a very interesting clinical approach. Dr. Baig is also Associate Director of the Chicago Center for Diabetes Translation Research. She is the past co-president of the Behavioral Research and Diabetes Exchange, known as BRIDGE. This is a professional society of behavioral health researchers in the field of diabetes. And her work, fascinating work, both in the clinic and in research activities, aims at eliminating Latino health disparities in diabetes. So both Gary and Arshia, thank you very much for being with us today. And I will start by presenting a few slides to set the stage for what we're going to be presenting. So I'll see you both in a few minutes. And let me then just share my screen now. Here. Okay. Okay. So let me start by just framing what we're going to be discussing today. And in this series, we have emphasized how some of our communities have been impacted tremendously by different clinical problems. And today is the day to talk about diabetes. It is not the exception by any means. And we do know that diabetes is a major problem in some of these communities. I do not have any conflict of interest for this particular presentation. But since we're going to be talking about many of these things, I want to go through some basic concepts that many of you are perhaps very familiar with, but it doesn't hurt to review them. When we talk about race and ethnicity, we're talking about two different constructs. Race refers to biological characteristics. These are our genetically determined features, so to speak, that makes us all very different from each other. For example, the color of our skin. So based on that, we have, as you can see on the left, categorized ourselves into different groups, like white, Black, American Indian, Asian, etc. Ethnicity, on the other hand, is a social construct. It is independent from race. And the best example is the Hispanic or Latino community, in which there could be very different racial backgrounds, but is a unified group because of the sharing of cultural and social characteristics. By the way, there's a difference between Hispanic and Latino, and I know that Dr. Begg will be talking about the population. Hispanic refers to people in the United States specifically that come from countries that were under the influence of Spain at some point. That is different from Latino. That is a broader term that refers to people for whom their language derives from Latin. So these are the Romance languages, and that includes people that speak not only Spanish, but Portuguese, Italian, French, and even Romanian. So there are differences there. But it's important just to know about these differences because we need to recognize that when we talk about these groups, there are different characteristics among them. And even within one single group, not all of them are exactly the same. And let me just illustrate that with this picture here that I put together, this collage of different pictures. And everyone that you see here on the screen identifies himself or herself as Latino or Hispanic. And again, these are terms that we use primarily in the United States. Now, I'm sure that you recognize all of them, and my goal is not to go through every single one of them, but just to illustrate that everybody's different. And you can see that the color of the skin is different, that features are different. That speaks to the different backgrounds. So genetically speaking, the Hispanic community could be quite heterogeneous. Having said that, in general, when we talk about racial and ethnic minorities, we're talking about basically the non-white community. And you can see here the projection for what it is expected in the next few decades in terms of the growth of these different groups in comparison to the white population. You can see the data here from 2010 and what is predicted for the year 2050. So 30 years from now, the white population is expected to be about 46%, with a significant growth for the other groups, and around 30% of the population is expected to be of Hispanic origin, and about 12% of the Black community. And that's important because we currently all provide care in the US to many of these communities, and it's important to really help them in the best way possible. But we're not really doing a great job yet. And that's the reason why we're having this seminar and we're having this full series. The Institute of Medicine, which is a federally funded organization, made a report some years ago about the fact that we are not providing care equally throughout the country. And this is a report that emphasizes how in academic centers and community-based clinics, hospitals across the country, even after controlling for access to healthcare and socioeconomic status, the quality of care that is provided to minority populations is lower than what it is provided to the mainstream white population. Not necessarily that we provide the best care to the white community. We should still try to improve that. But clearly, there are some communities that are lagging behind. And that should make us reflect on why we are having these disparities. And I always like to think about these three main domains: the patient, the provider, and the healthcare system. And you can identify that there are some particular elements in each of these three categories that may contribute to the fact that diabetes care, as well as other diseases, the care of other diseases is not the same in some of these groups. So we'll elaborate a little bit more into all this, but eventually, if we are really serious about eliminating healthcare disparities, we need to tackle possibly all these different elements one way or another, and that's obviously a challenge. Now, disparities exist in the field of diabetes, and let me start by saying that the prevalence of the disease, primarily type 2 diabetes, which is the most common type of diabetes, is higher in some of these communities compared to the white community. You can see here the data on the left on the total diabetes prevalence. Let me emphasize that these are the data from the National Health and Nutrition Examination Survey. This is the NHANES, which is a program that has evaluated non-institutionalized populations across the country. That may not necessarily reflect what you may see in your clinical practice, but these are the national data that we usually share. You can see that the prevalence of known diabetes is twice as high in Blacks and Asian and Hispanics in comparison to the white community. Also of note, the prevalence of undiagnosed diabetes. So these are the people that participated in the program that did not know that they had diabetes when they joined, is much higher in some of these communities. It may catch your attention, the fact that the highest number is for the Asian community. I personally believe that may be because the Asian community may develop type 2 diabetes with a lower body mass index, and not everybody may be aware that that's a risk factor, and therefore there may be more people with undiagnosed disease. But suffice it to say that both diagnosed and undiagnosed diabetes are more common in these groups. In addition, and I'm not showing you the data, but there are about 88 million in the United States. 88 million people with pre-diabetes. So this is the prior stage to the development of type 2 diabetes. So 1 in 3 adults in the US have pre-diabetes, and many of those are also members of racial ethnic minorities. So why is this happening? Are there any specific factors that lead to the development of diabetes and complications in these groups? Well, you can see here at the center of the slide that there are several pathophysiological elements that we have recognized over time that contribute to type 2 diabetes. And I can say that some of them have been identified to be more frequent in some of these communities. For example, you can see here insulin resistance and abdominal obesity. This is a feature that has been identified more commonly among Latinos, Hispanics, and even other communities like Asians and African Americans. Beta cell dysfunction, which is the hallmark of diabetes, that's the inability of the pancreas to produce insulin, seems to be a major problem in some of these communities and may happen in younger individuals as well. I put a question mark here for some of the other abnormalities that have been studied, like appetite, satiety, incretin dysfunction, et cetera, that we still don't have a lot of information, but in the pathophysiology, there are some biological elements that we can recognize. However, I personally believe that the most important factors are not the biological ones. As you can see here, lifestyle issues, socioeconomic factors, and cultural factors contribute to the development of type 2 diabetes. And that is the other element that we need to pay attention to. And ultimately, people develop diabetes complications if the disease is not well treated, et cetera. And there's also disparities in diabetes in terms of the inability to achieve basic treatment goals. These are the data, again, from the National Health and Nutrition Examination Survey on people's ability to achieve good glucose control. This is based on A1C, glycohemoglobin, A1C levels. And you can see here 3 periods: the period from 2005 to 2008, the one from 2009 to 2012, and the one from 2013 to 2016. And you can see that overall, despite all the advances in diabetes care, we have not made a lot of progress. And you can also appreciate that it's a little harder for some of these communities, even though there's not a huge statistical or a huge difference that did not reach statistical significance when making all these comparisons, but seems to be a little bit more difficult for some of these communities. Here you also see the data, not just for diabetes control, but the ability to control blood pressure, cholesterol, and also the advice on non-smoking. And you can see here that in particular, and we have known that for years, the Black community has a more difficult time in achieving good blood pressure control. And also for cholesterol control, it's less likely for Blacks and Hispanics to achieve that. Not a lot of difference for non-smoking. And here you see the combined goals. And for example, for me as an endocrinologist, and for Dr. Baig as well, when she sees her patients with diabetes, this is what we aim for. Having good control of their A1C, that's diabetes control, blood pressure, and cholesterol. And when you look at this, first of all, we're not doing a great job in the white population either. Most patients with diabetes in the white community are not at goal. But in the Black and the Hispanic community, the problem is even bigger. You can see that there's less people that can achieve this goal. So that means that only 1 in probably 5 or 1 in 7 individuals have achieved treatment goals. That's not correct. I think that we need to do a lot more to help our patients. So I just want to finish with 2 slides. This one is about trying to make you reflect on why we have all these healthcare disparities and we're not doing a great job in diabetes care despite all the scientific advances. And I would like to think about the fact that we all work in a healthcare system. You do that, obviously. You interact perhaps, or you are in establishing many programs. And we ultimately want the patient to improve diabetes self-care behaviors. And that would lead to better glycemic control and prevention of complications. Well, I think that we're doing well in general when we look at the biomedical piece. So we're good at addressing the medical pieces here, but we're not very good at addressing psychological issues, social issues, financial issues, and many other things that influence diabetes care. So on the left-hand side, I have included here this term called cultural humility that speaks to the fact that we all as healthcare providers need to become more aware and able to provide care to everyone, regardless of race and ethnicity, but even more so for those people that are not being helped in the way that they should. And the final piece is this. I created a couple of years ago a list that I call the A to Z for the management of diabetes in culturally diverse populations. My goal is not to go through the whole list, but just to invite you to reflect on the fact that some of these factors are important in diabetes care. Many of them are particularly important in racial and ethnic minorities, and we don't usually address them in clinical practice. If you're a clinician and you're following this presentation, I would invite you to think about how many of them do you evaluate in your clinical practice routinely? And that is something that probably we don't do well. We don't do well with psychological issues, depression and emotional distress. We don't usually address health literacy, or we don't address completely whether people are taking their medications, nutrition issues, religion, socioeconomic status. There's obviously this unconscious bias that we may all be subject to, and we don't know exactly how to empower patients sometimes. So this is an invitation to reflect at a bigger level, not just the biomedical piece, in order to improve diabetes care for these and every single one of the communities that we serve. So thank you very much for your attention. I have my email there in case you want to send me any notification or any message, and I'll be happy also to share any of the publications that I refer to if you're interested. So with that, I am going to stop sharing here my presentation, and I am going to now invite Dr. Gary Puckering to come on stage and give his presentation about the wonderful work that he's been able to integrate in this field. So Gary, take it away. Thank you. We can hear you.
Thank you so much.
Yeah.
Want to make sure I'm showing my video. Okay. I normally, when I talk about diabetes and the diabetes crisis, I don't normally talk about it in terms of dollars and cents because I think that our healthcare system pays so much attention to financial risk that it doesn't pay enough attention to patient risk and making sure that we are providing optimal care for patients. But what I decided to do today for today's presentation is to take you a little bit into the dollars and cents from the taxpayer's point of view about diabetes, because typically people who don't have diabetes and trouble with it don't understand the burden that it puts on society, generally speaking. So I want to introduce you to a little bit of the numbers at the population level to explain how diabetes is, in effect, impacts us all. So when I look at diabetes care, I tend to focus on hospitalizations and ER visits. We publish something that we call the Diabetes Index. We've been publishing that now for almost 15 years. And in it, we are mapping diabetes by zip code and county and congressional district, et cetera. But one of the things that strikes me the most when I look at data from the Diabetes Index is roughly 60% of everyone with diabetes has a hospitalization or emergency room visit every year. 60% of everyone living with diabetes is either ending up in the hospital or an ER visit. And it doesn't matter if it's in Medicare or Medicaid or commercial insurance. Age doesn't seem to make much difference to the number. And then when you add comorbid conditions on top of it, those rates increase. The Medicare and Medicaid programs, that's where we find the greatest number of hospital discharge for diabetes. Diabetes being the underlying condition, the comorbid condition, and sometimes even the primary condition. But the point here is that 76% in the United States of all of the hospital discharges with diabetes as a primary or comorbid condition is happening in the Medicare and Medicaid program. If you look at ER visits, it's about 79%. And the reason why I'm calling those numbers to your attention is because that's where the taxpayer dollars go. If you look at the Medicare program, roughly about 40% of every dollar spent in the Medicare program is spent on treating patients with diabetes. It is a disease that has tremendous impact on budgets as well as on patients. And here, I'm just combining, we call it hospital encounters. If we combine the ER visits with the inpatient stays, you're talking almost 19 million separate events. 19 million separate events in the Medicare and Medicaid program related to diabetes. And our argument is that many of these events are avoidable. If we are treating patients according to clinical guidelines, we could reduce these emergency room visits and hospitalizations tremendously. And so I'm showing you right now aggregated numbers, but I want to sort of unpack this a little bit more so you have a better understanding of what diabetes care actually looks like in the United States. So what we've done is we've taken, this is the Medicare program, but we've done this in the commercial world as well, commercial insurance. So we take every patient and we put them into 5 groups based on how much was spent on their care in 1 year, exclusive of prescription drugs, because prescription drugs, they vary depending on what plan you're on and things like that. So here we're capturing hospital visits, ER visits, physician visits, durable medical equipment, et cetera, et cetera. And we have one group that we call low consumers. Roughly, we're spending under $1,000 a year on their care. They represent about 34% of everyone with diabetes in the Medicare program. And I'm saying to you, you'll find the same statistics in commercial plans as well. And roughly speaking, we're spending under $1,000 a year on the care of low consumers. And so one of the things that we did was we took the ADA clinical guidelines and we went over to the Medicare payment schedule and said, so if you were following ADA guidelines for diabetes care, what would that cost? Because the point is that if a patient is well managed, they have a specific cost profile. And the point I'm making here is that these low consumers do not meet ADA guidelines. The care that they're receiving is under ADA guidelines based upon how much is spent on them. At the top of the pyramid here, these crisis consumers, in 2017, Medicare is spending about $160,000 a year on their care. They have high levels of hospitalization, and their mortality rate is somewhere around 25 to 30%. And so, in effect, how the system goes is these low consumers, and by low consumer it doesn't mean, and I'll show you shortly, that doesn't mean that they don't have ischemic heart disease or chronic kidney disease or heart failure. They have all of those conditions, except they're not being treated for them. So what happens is these low consumers migrate up the pyramid. They become the crisis consumers, and once they get here, they have a high mortality rate. So in about 3 years, this group is replaced by another group that's migrating upward. And that's where all those hospitalizations that you see. From crisis consumers to moderate consumers, it's all driven by hospitalization costs. And so the point is, if you look at those where we don't have a lot of hospitalizations, about 10% of the Medicare beneficiaries who have diabetes do not have high levels of hospitalization. Only 10%. The other 90% have high levels of hospitalizations and hospitalizations cost. And that's the point I'm trying to make to you, is that we're failing, right? We are treating people with diabetes in the emergency room, in hospital, because they're not being well managed. And there's a real need, we would argue, to reduce those diabetes-related hospitalizations and ER visits. So this brings us to the point. So when you think about the diabetes care down at the community level, if you go down to the community level, counties, cities, et cetera, what you find is that there's a collaborative network that is providing care. Ideally, that collaborative network is being driven by evidence-based medicine. And what I would quickly say to you is that part of our challenge is that policymakers don't necessarily follow evidence-based medicine. If you look at programs like Medicaid and Medicare, there are policies that are being presented that impact patients and the ability of physicians to provide care and have nothing to do with evidence-based medicine. And so the point is, what we need is this collaboration to work together following evidence-based medicine to get the best possible outcome for patients. So when you're talking about health disparities, what you're really talking about is that for whatever reason, down at the community level, this collaboration is not working very well. It could be, some of it could be the patient in terms of them not being adherent to the guidelines. Some of it could be policy. Some of it could be the way in which care is delivered. Maybe the patient advocacy groups are not strong. But the point I'm making is that to fix the problem, we really have to make sure that this collaborative network is working well and that we're using evidence-based medicine. And certainly one of the things that I would encourage us to say to our policymakers, if you don't follow the evidence, you're going to get poor patient outcomes at the other side. So let's start to drill down a little bit to the patient level to give you a sense of what I'm talking about. So here I've mapped, this is Medicare fee-for-service. This is out of our diabetes index. And we're looking at low consumers. If you remember, those are those folks at the bottom of the pyramid where Medicare is spending under $1,000 a year for their care. And we're just focused in on African Americans. And you can see one of the things that's really interesting about African Americans is that there are 38,000 zip codes around the country where people live. 70% of African Americans live in 2,500 zip codes, and those zip codes are in the southeastern part of the United States. So when you're talking about health disparities for African Americans, is clustering right down here. You can see in Chicago, out here in the West Coast as well. So there are about 1 million African Americans in the Medicare fee-for-service program who are being treated for diabetes. 274,000 of them, roughly a third of them, are those low consumers. If you remember, I told you before that low consumers are somewhere around 34% of the Medicare population who's being treated for diabetes. So this is a map of where those are for African Americans. Remember I said to you that those low consumers had low hospitalization rates? So here we're looking at that 274,000, and they just had 4,000 hospitalizations, right? And that's the point about these low consumers. That's why they have that low cost. It is not because we're delivering them appropriate care. It's because they, like everybody else, for whatever reason, that particular year, they didn't go to the hospital or they weren't in the emergency room. And again, remember that when we look at those high-cost patients, is primarily driven by ER visits and hospitalizations. So this 274,000, they have about 1% hospitalization rates. But that hospitalization does not tell you the real story, right? So what I'm now mapping for you is those treated with diabetes. Again, these are the low consumers down in those communities who also have heart disease. So that not only do they have diabetes, but they're being treated for heart disease. So of the 274,000, 223,000, over 90% of them have heart disease, along with their diabetes, right? So low consumer does not translate into healthy consumer, does not translate into a consumer with a low risk. It just means in that particular year, unfortunately, the way we deliver diabetes care is that they didn't end up in the hospital. What I'm showing you here now is, so what did those patients cost? So these are the diabetes patients. They have heart disease, and here is the average cost per patient, $869.15. That's what they cost for those 223,000. I will tell you, you cannot manage diabetes and heart disease on an average per patient cost of $169 a year. That is just not going to happen. You can't even manage diabetes, let alone heart disease, for that amount. And so I want to take you to the other side of the house of those crisis consumers. So these are the blacks who are at the top of that pyramid that I showed you. We call them crisis consumers, and there were 42,000 of them, and they cost $160,000 a piece. $160,000 a piece, and $6 billion we're paying for 42,000 patients. And if I go back to the low consumers, 223,000, we're only spending 194,000 on the 223,000, but on the 42,000, we're spending almost $7 billion. That's the point. That is actually the point. Because
Please wrap up. Please wrap up.
I'm sorry. Okay. Yeah, because we're not managing those patients well. And so what we see in those crisis consumers is that they have a mortality rate of 25%. And so the data tells us that we are not being very good as we manage patients with diabetes, and we can go into those communities and identify those patients.
Great. Thank you so much, Gary. That was very interesting information. I think it reflects the fact that we have a serious problem, obviously, in managing diabetes. So thanks for making that so evident with the data. So Arshia, it's your turn now. So I think that everybody wants to know, okay, that's a big problem. What can we do? And I think that your experience in your clinical and research areas is really very interesting. So please share with us a little bit of your work.
Great. Thank you so much for having me today. I'm really excited to talk about some of the work I've been doing in Chicago and the Midwest. Hello, everyone. So I'm a primary care physician and health services researcher here at the University of Chicago, one of the associate directors for a diabetes translation research program. I do have some funding from the National Institutes of Health and also the U.S. Department of Health and Human Services, Office of Minority Health. And also I've received some speaker honoraria from the American Diabetes Association. So Latinos in the U.S. carry many barriers to, or have many barriers to care. So some of it gets down to, some of the socioeconomic issues. So the average Latino household in the U.S. owns just 7 cents for every dollar held by a non-Hispanic white household. And there are many barriers in the built environment. So violence, limited space for exercise, poor access to fresh food. And these are many things that I hear from my patients in terms of difficulty in going out and walking in the neighborhood. We're talking about eating fresh fruits and vegetables, but then where do you go to get those things? Can you afford them? Other issues, so language barriers. So 76% of US Latinos speak Spanish at home, and that's per the last census. So I think that just says something about the language that maybe they're comfortable getting their health care in. And then in terms of access to care, so on average, the US 25% of US Latinos lack health insurance. However, if we disaggregate the data, this really ranges from 17 to 49%. So again, hearkening back to Dr. Caballero's talk about how we really need to be looking at subgroups and there's so much diversity. So there's just one example of how insurance status varies. So if you look at the US, the overall percent is about 14% of people do not have health insurance. And this is from a few years ago. Hispanics overall, 25% do not have health insurance. But if you look at the range here again, so US born Hispanics compared to foreign born Hispanics, there's a huge difference. And many of the communities that I work with here in Chicago, there are foreign born Hispanics who are non-citizens, about half do not have health access or insurance, which relates to access to healthcare. So drilling down to diabetes in Chicago. So Chicago actually has the 4th largest Mexican American population in the US, and Mexican Americans make up the majority of Hispanics here in the US. I am here where the star is at the University of Chicago. Most of my work has been in South Lawndale. So this is just a map of Chicago, and we see these are the different neighborhoods. And South Lawndale is most of where I do my research. And in this community, also called Little Village, La Villita, 83% are Latino, 76% are Hispanic. In looking at some of the socioeconomic factors, so 60% of the folks who live in this neighborhood live below poverty. Only 40% have a high school diploma. About half have health insurance. And the average body mass index is 37. So again, we're seeing many of these risk factors in this community. So as we all know, diabetes self-care is very important in managing diabetes. So that goes all the way from eating healthy to exercising to taking your medications. And then the education around self-care is even more important. So, based on US data, so many Latinos actually do not participate in self-management education. Only about half have reported that they have. So, and this comes from Healthy People 2020, which are targets that the US Department of Health and Human Services wants us to move towards. So my work has been with churches in LA and then here in Chicago. So, churches can provide a very familiar, convenient, and trusted setting for diabetes education and support, and they can be very central to many communities. Yet there's actually very few interventions for chronic diseases in Latino churches. You see lots of flu vaccination fairs or health fairs, but not too many that have been integrated, not too many educational programs that are integrated into the church. And this is one of the churches that I've been working with here in Chicago. So I worked with the Community Advisory Board of leaders in Little Village. So health center directors, church leaders, community organizations, leaders of these organizations, and just community people who either had diabetes or were taking care of people with diabetes. And we came up with our intervention, Picture Good Health. And we designed this based on the literature, based on focus groups that we did within the community. And we had these core intervention components. So one was educational curricula, which we based off of nationally published curricula, but we tailored it to our community here in Chicago. We had exercise groups that were already happening within the churches, so we connected patients to those. We had patient navigation, so knowing that medical care is really the core tenet of care for adults with diabetes, so making sure that people were plugged into primary care. We had photo voice, so that's a public health technique really, where people take photos of their lives with diabetes, and from that, we use those photos in our weekly group sessions that were led by lay leaders whom we trained. And we use these photos to jumpstart conversations around challenges and successes in diabetes management. And all these components were part of this eight-week self-management education program. So what did we find? So we actually found that in the usual care arm, so these folks just got a lecture on diabetes. They had some improvements in diabetes self-care in terms of consumption of fruits and vegetables and testing their blood sugars. In the intervention group, we saw many more changes in their diabetes self-care. When we looked across arms, we still found that the folks who went through our intervention were eating less high-fat foods and participating in exercise more. And this is just from a 8-week intervention that was led by a lay leader. At times, I think in my clinical practice, it is so hard for me to just through my counseling to motivate my patients and actually see changes in self-care, and yet we were able to see these. So that intervention was mostly focused on communities, working with communities and with patients and supporting patients in a familiar setting. Then when we get into what's happening in the encounter, in the clinical encounter, we see what's happening with providers, and what patients are reporting. So about 60% of Hispanics understand everything that their doctor said and feel their doctor listened to them. And that actually is fairly low. I actually think looking at all of this, that as a primary care physician, it makes me sad to think that there are folks who are not really they're leaving and feeling that their doctor didn't listen to them, or that they were, not everything was understood. But you'll see that for Hispanics and Asians, these numbers are even lower. And then when we look at people who are leaving their doctor's office with unasked questions, 19% of Hispanics are leaving and they didn't get all their questions asked. Now, so when I look at this, it makes me think, well, what's happening in terms of patient-provider communication? So again, working in this community, we designed a study called Local Patients, Local Stories, and this is through pilot funding through the Schrupp Foundation here in Chicago. And this really branched from our church-based intervention, where we heard patients talking over and over again about provider communication challenges. And then we also looked at the national data. So we learned about these patient challenges, and we designed this program based on really patient-centered communication. So we looked at what there was in the country in terms of provider cultural competency training, and we actually found that a lot of times it was very generic and it wasn't necessarily targeting the community that the patients were living in or the providers are taking care of. So we designed this 2-hour training program with skill building and patient-centered communication. And we used a video of our patient stories and photos from our church-based intervention to talk about the challenges and successes that patients had in tackling their diabetes care. And we also informed providers of local resources. So how many pharmacies, how many parks, where are the food pantries in this community. So coupling the skill building along with local resources. We piloted this with 42 local healthcare providers, and that included nurses, MD, physicians, physician assistants, and nurse practitioners as well. And we found that actually our providers, they had an increase in their knowledge, so they learned more about the resources in the neighborhood that they were taking care of patients in, and where of local resources they could refer their patients with diabetes. And then also we found that their cultural awareness scores also improved. And this was just pre to post training in terms of their own biases and how that reflected in their care. And then actually, I don't have this data here, but at 6 months, we re-surveyed our participants and actually found that these scores either increased or stayed about the same. So somehow this 2-hour training prompted people to learn more. So then thinking about, well, what's happening at the health center level? So we've talked about patient, provider, and health centers. And health centers here in the United States actually care for one out of every 13 Americans get their primary care at a health center. So clearly a very important system in the US. Also, they take care of many people who have who are low income. So I think about 70% of health center patients are low income, and about half of health center patients are actually people of color. So we started working with health centers here in the Midwest, and we piloted this health group visit intervention, where we had 3 urban and 3 rural health centers from 5 states, and we had them recruit patients with diabetes with an A1C above 8%, and they implemented the 6-month training or 6-month diabetes group visit program. We actually trained the health center staff on how to go back and implement these programs. So you'll see some photos here of our training. The health centers enrolled 51 patients, and more than half attended more than 4 of the visits. In terms of patient-reported outcomes, people improved the number of days that they were eating healthy and testing their blood sugar. So we're happy to see this from baseline to 6 months. We also found an improvement in A1C. So our criteria was to enroll patients with an A1C above 8. Our average was 10, which I think just notes some of the struggles that some patients are having in controlling their A1Cs. We did see a decrease in our intervention group in their A1C, now averaging about 9 compared to our control group. And there's just a historical chart control of patients who were getting usual care. We sort of saw what the trend was at the health centers as well. So in summary, Latinos suffer from disproportionately high rates of diabetes and have many barriers to care. I think these multi-pronged interventions are actually really important. So thinking about working with community partners and patients, and then designing these interventions to address patient, community, provider, and health center interventions is actually really important. And ultimately, we want results that are practical and relevant to patients and policymakers. So many of our health centers have, who were in our pilot, they have actually continued either group visits or are applying them to other disease or conditions in their health centers as well. And right now, we're actually in the middle of a cluster randomized trial funded by the Office of Minority Health to expand diabetes group visits to more health centers across the Midwest. So our next targets are hopefully family-based interventions, because we know that people aren't just managing their diabetes by themselves, but that they are within a family, within a community, thinking about that. And then also diabetes distress, which actually Dr. Cabrera was also talking about. So the emotional part of diabetes is actually really important as well. I have lots of acknowledgements to my funders. It takes a village to do much of this work. And I'm happy to take any questions. And here's my email if anyone has any questions.
Thank you, Arshia. That was a great presentation. So at this point, I want to invite Gary to also join us. We have a few minutes before the end of the program. Thank you both for your great presentations. I think that we've been able to really convey a lot of information so far. Before I ask you a couple of questions, I just want to clarify, because I do know that there are people in the audience that are outside the US. So what we have discussed here primarily relates to healthcare disparities in the US, but this is something that is a worldwide problem because in many countries, there's also groups that are lagging behind. So many of the things that we discussed here may be applicable to some other communities. And the other piece is that we have emphasized what happens mostly in the Latino, Hispanic, or in the African American community. But not to forget that even in the US, of course, there's other groups, the Asian community, the Arab community. The highest prevalence of diabetes is in the American Indian community. For example, the Pima Indians have the highest rate of diabetes. 70% of those above the age of 35 develop type 2 diabetes. So we're talking about a few here, but this is obviously a problem that affects many other communities. Having said that, then let me just then ask you a few questions. Gary, thank you for that perspective. And I can't obviously avoid asking you, since you are also involved in the history of all these different problems now for many years. I think you gave us a good snapshot of what the problem is now. And clearly, I think there's still a lot of room for improvement. But if you look back at when you founded the National Minority Equality Forum, are we making any progress? Is this getting better in any way? Or is your sense that we're just not even moving in the right direction? How would you address that? We can't hear you, sorry.
Yeah. In the world of diabetes, actually, we're not, right? So when we started mapping diabetes, about 3% of the U.S. population had diabetes. It's now about 9.5%, right? The hospitalization rates have not changed.
Have not changed.
Have not changed. So given all of the new therapies, I mean, we've got some fabulous new therapies that have come on stream, but they're not breaking those numbers. In fact, on the course that we're going, by the time we get 2030, we won't have enough hospital beds for people with diabetes. We talk about COVID, but by the time we get to 2030, given the rates of hospitalizations, it'll be impossible to hospitalize everyone who's going to reach here with diabetes. So there really is a crisis that we have to address in diabetes, and try to figure out why are we really doing most of our diabetes care in critical and urgent situations.
Yeah. So it seems like we're acting late. We continue to acting very late. It's really still a reactive system, right, in which we take care of those people that are sick when they go to the hospital, but we don't do much yet in terms of prevention strategies, in terms of early detection to try to control diabetes and other comorbidities early to prevent the development of complications. And that's basically the price that we're paying. I think there's been progress, but I agree with you. I think it's a major issue, and we haven't really been able to do that completely well. But Arshia, perhaps the follow-up question would be, and I think that you have shared very nicely what you do in your program, and I'm sure that you started somewhere and somehow, right, to get this going. But for the people that may be hearing this presentation who say, yeah, I get it. I think that it would be great to develop something to help some of these communities, whether that's Latino or the African American or any other community. What would be your advice in terms of how to start these process going? Because what you have achieved obviously took many years and involves a lot of different parties and support, et cetera. But what would be your advice to those people that are interested in joining the fight against diabetes in some of our communities?
Yeah, that's a great question. So I think that there are so many local community resources that our patients can access. So I think, working within our health system, working with our social workers, our educators, and trying to identify some of these resources and plugging patients in is really important. So is it that there's food insecurity that's an issue for the patient, that they can't afford or have access to fresh food? Or where are there farmers markets? Are there food pantries in the neighborhood that people can go to? What about opportunities for exercise? Like here in Chicago, our museum here has walking facilities, that people can go inside and walk for seniors, I think like early in the mornings. So thinking about what are these local resources and how do we get our patients plugged in, I think is really important. I don't think that we have to start from scratch. I think from the provider perspective, I love the cultural humility in your A to Z approach. I think that just because, even within this neighborhood of Mexican Americans I'm working in, actually this video that we made showed the diversity. I mean, this is just, people from one block to the other block or one house to the other house. Some people are having a hard time motivating to go walking. Other people are marathoners. There are some people who finished 8th grade. There's some people with MBAs, all within the same community, but they're lumped together as being Mexican American, immigrant, Spanish speaking, yet they're so diverse. So I think it's really important to take the patient that you're talking to and understand where they're coming from. What's important to them. What are their challenges in addressing those?
Yeah, no, I think that's great. It's getting to know them more. But I also like what you said. I think that it all starts with us as healthcare providers being aware of the need to do things differently to provide care to these communities. And I am afraid that we may be sort of preaching to the choir right now, because everybody that has joined this program are, I'm sure, people that are interested in this, but there are so many physicians or healthcare providers in general that are probably not aware that there's room for improvement. And people may say, I'm so busy doing my day-to-day work that I don't have time for all these other things that you're asking me to do, especially when people are busy in clinical practice. I have to say that at Harvard Medical School and also at the Brigham and Women's Hospital where I work, we have taken this very seriously. And now it's really nice to see that there are so many efforts to try to bring awareness about racial justice, about health equity, about biases in healthcare, et cetera, all these things that are important. And I hope that people can sort of strengthen those efforts in across the board in different organizations. So thank you, Arshia. And Gary, one question. I'm sure that you've heard this before because we've had many different conversations over the years. But one question that I always get, and I would like to get your thoughts on that is, so is it race and ethnicity, or is it just all the social determinants of health that explain why the African American community, Latinos, have more diabetes and more of these problems? So what about, for example, the white community that has similar social challenges as what we have identified in the other communities? To what extent is it really race and ethnicity? And I know that it's hard to sort of separate them, but what are your thoughts on this?
Sure. So certainly there are differences in the biology that make some populations more susceptible to diabetes, as you suggested, with the aging population. With lower BMI, they still have this high prevalence of diabetes. I think what the real challenge, though, is the tiered healthcare system, which is the way in which we provision healthcare makes it so that I remember once we were doing a study down at the Texas border, and what we saw is that many of the Latino patients were coming into healthcare in the Medicare program, and when they got into the Medicare program, they already had the diabetes had already turned into ischemic heart disease and other problems because they came into the system late. So they were crisis consumers almost at the point of entry, right? And so that's the point. It is not obviously the biology presents a risk, but how do we deal with that risk, and how do we make sure that we anticipate that? And it also goes to your earlier point about prevention. We really don't do prevention very well.
Yeah, I agree. So thank you for sharing that perspective, Gary. And final question, Arshia, because we're probably going to need to close the program. And I personally love the group medical visits. I actually was able to implement them at the Charleston Diabetes Center where I was before. And but maybe not everybody's familiar with those in more detail. Can you maybe just give a brief summary of what they are, how they work, and you share a little bit of the outcome, but just as a refresher for everybody.
Yeah, so diabetes group they're actually like shared medical appointments. Yeah. So it is a medical appointment, but it's within a group setting. So usually you bring together a group of people with a condition. So here, type 2 diabetes. and maybe 8 to 10 people within a group setting. The visit's about maybe 2 hours. It can range from 1 to 3. And within those couple hours, people get education, so on a topic. They can get their refills, they can get their labs checked, they can get vitals done. And then usually there is a short medical visit that is a part of it also, where patients are usually pulled out for maybe like a very short, very focused diabetes visit, like 5 to 10 minutes, where a physician, healthcare provider can review labs, titrate medications, prescribe medications, place orders, place referrals. So it's kind of like a one-stop shop for people, you know? So instead of having to take time off to come get your flu shot and get your labs done and pick up your refills, hopefully you can just get it done within a couple hours. But on top of that, meet other people, learn from other people who have a similar condition.
Yeah, and you're really tapping on the cultural preferences, right? Because that works well, definitely with the Latino community, perhaps with other communities as well. But I think it's important to be innovative. And this is a time, I guess, that we're all trying to come up with new strategies in terms of how to provide care to our patients. So yeah, thanks for sharing that. All right, then I think it's time to close the program. I'll just then want to thank everybody for joining us. Hopefully this was useful. We wanted to give you some thoughts. Clearly, there's a huge challenge in the field of diabetes for everyone. And I think that we should take care of everyone, regardless of race and ethnicity. But there's no question that there are some groups that are lagging behind. And what we wanted to share with you today is how serious this problem is, and also to provide you with some options, some success stories, and some ideas about how to improve the care of these populations. So Gary Pockering, thank you so much for joining us. And you're very busy, and continue with that fantastic work that has helped us all having better evidence of what is happening. And Arshia, thanks for sharing your experience in both the clinical and the research arena. So thank you, Dr. Pei. And just as a reminder for all of you, you may be able, if you see at the bottom of this video, you can go and do your evaluation, and you can claim your credits. In addition, you will receive an email from our team with all the information and the link to watch this video when that is ready. If you want to do that again, or if you want to share that with other people, feel free to do that. And you can also claim your credits later on, and whoever watches this video later. And remember that this is just one of the several webinars that we have in our series that hopefully will bring some light to everyone about the importance of social justice, of race and ethnicity in healthcare, and hopefully we will all contribute to a better society and a better world. Thank you very much for joining us, and see you.